Hello, and welcome back to Learn It from a Layman. I am Carl Christensen. I'm joined tonight by Matt and first-time podcast guest, Natalie Vogel. Hi, Natalie.
Hello. Hello.
We're super excited to have you on, Natalie. You're a physical therapist, um, and we're going to talk about the basics of physical therapy tonight. As a little bit of background, you've been doing this for a couple of years now, and
Yeah.
you tell us like what your educational background is as well.
Yes. So I took kind of the longer route to get to where I'm at. So I don't know if this is exactly what you wanted, but I got a bachelor's degree in sign language because I thought I wanted to be an interpreter for a while, which I was, and it was good, but the freelance style is not my vibe. I really value
Okay.
security and have very low risk tolerance. So I went and got a master's in public administration, thinking I would do nonprofit work. Turns out you don't really make a lot of money there. And
Just the
the other
nonprofit
yeah,
designation.
right? Something about that. But also local government is kind of the other option that my program kind of steered us toward, and that was definitely not for me. So then I was looking for something else to do, and at the same time I had just graduated from my master's program. I decided I was going to work out finally. I had the time and I got injured, so I went to physical therapy, and I was like, what is this? This is cool. I want in. And so then I had to go back to school to take some prerequisites to apply to programs, and then it's a 3-year program after your bachelor's if you do the straight track.
Interesting. So you got sucked into physical therapy by doing with someone doing physical therapy on you.
Yeah.
Wow.
Yeah. It's
That's
awesome.
I mean, I wonder how frequent that's the way that people come in. I'd imagine that it's more you know uh just anyway, that sounds unique to me, but that's awesome. Okay, well,
Sells itself.
exactly. Tells you how awesome the profession is. Well, let's start a little bit then about I Natalie, you know the podcast titles, Learn It from a Layman, so I'm not I'm pretty unknowledgeable. I could probably stop the sentence there, but I was going to continue by saying I'm pretty unknowledgeable about physical therapy, and so give me physical therapists. Do you specialize on a particular body part, or is it I'm a physical therapist, therefore I can do all things?
Um, Theoretically, you're a physical therapist, so you are able to do basically anything. It's a lot more broad than I think most people know. So I feel like the most well known is the, muscle or joint injuries. You have like a knee replacement, you go to an outpatient clinic and you get exercises and they do their little muscle work on you and then you get better. But there's tons of different specialties. So like I work in a hospital and I work with the people who, like, I typically work in the cardiovascular ICU. So people who had open heart surgery, who have like the day after they have a stroke or a brain injury, car crash, all kinds of different injuries or illnesses. And I just help get them out of bed and like moving again. Um, there's like 10 different like clinical specialties that you can get, that are like cardiovascular and pulmonary. And so that's more of like what I do. I'm not in that specialty. These all require that you like take a bunch of continuing education and like pass a test. But
Okay.
there's like geriatrics, neurology, that is usually with like spinal cord injuries, strokes, traumatic brain injuries. There's like a women's health, which I think they're trying to transition that to be pelvic floor in general. So it's a lot of postpartum women or like pregnant, but men have pelvic floors too, and they can have problems with that. So
Okay.
they can treat men as well. There's like, they can do wounds, there's pediatrics, there's oncology. So there's tons of different ways.
Specialties.
Yeah,
Right.
and I
Okay.
know some people do specialize in a joint area. So like some people are like TMJ specialists for people with like jaw issues, or you can have like vestibular specialties who work with like concussions or vertigo or dizziness or those sorts of things. So it's really, really broad as far as the field goes. So I feel like if you're not happy with where you're at, then there's probably a place somewhere else for you.
Other options.
Yeah.
Okay. I was wondering, you said in your background, you got your degree in ASL, right?
Mm-hmm.
Your undergrad. Yeah. Has that been useful to you as well in physical therapy?
Really has been.
Yeah.
So I'm not certified to interpret anymore. But when our interpreter service is down, I have used my signing to communicate with patients. They know I'm not certified, so I will
Sure.
I'm not trying to do anything illegal, but yeah,
right,
it's super useful, and patients really appreciate that I can like understand them directly and communicate with them. It's not something that most patients who use sign language or who are deaf get to use that often. So it's kind of fun.
Yeah, that sounds awesome. Sounds like a big plus to working with working with deaf patients. We probably circle back around. I'd be a little bit interested to see, if you're working on people with those types of disabilities, what the special, things that you've got to do, like you said, an interpreter or whatever. But let's follow. I sent you a list of questions. We can kind of walk down those and then explore some of these other. Okay. Well, I as a layman and knowing just some very basic things about physical therapy, physical therapy is it generally to help avoid surgery, or is it post surgery?
Yeah, all the above. Yes. Okay. It's really the big phrase that they use in physical therapy is it depends. And so you just have to be like, okay, what does it depend on? And I guess for most people try to avoid surgery. And so in a lot of cases it is to try and put that off to see if they can stabilize the joint or ligament or whatever that is the problem, to see if you can like strengthen the muscles around it well enough to stabilize it so that you can just do your day-to-day things. Or if you have to have surgery, because sometimes, muscles can only help arthritis so much. So people get like knee replacements, or, athletes get their ACLs repaired or whatever. Then PT, I think, is like the best way and the most efficient way to like get back to your prior level, whatever that may be.
Sure. So do your clinic, you say you work in a hospital, right? Mm-hmm. So you're probably mostly working with people that are dealing with post-surgery. Is that true for you?
Yeah, that is true for me. Yeah, largely, okay. I would say, yeah, they're pretty acute. So I'm like the first person to get somebody out of bed after a surgery. I don't, in general, with my role, I don't really see how people progress much outside the hospital with things like joint replacements or like spine surgeries, or shoulder surgeries. I saw them during my clinicals at school, so I kind of have a general idea, but something that happens like after a car crash or like a freak accident, I don't really get to see how those particular people recover very well.
Got it. Okay. So I guess kind of in that vein, then does I guess in your case, and then what you've seen clinically and just generally in the PT field, does each injury disease require different approach, different therapy? Or like if someone just had surgery and has been laying in bed for a week or whatever, in your case, is it always, I know that these are the things I've got to do with them in order to get them mobile? Are there go-to therapies depending on body part, or is it just, do you work up a therapy plan individually?
I would say largely it's kind of the same general things. So like after a joint replacement, you want to get range of motion first so that they can move it before you really start trying to like get the big muscle movements with weights going. Mm-hmm. So, like there's the general set, like, okay, that's the general order that you would do things. But as far as how you go about doing that, it's pretty individual based on like how much pain that person's in, what they could do before surgery, how fast they're progressing. So I would say largely it's pretty individual, but there is kind of a general pattern that people will follow no matter where you go. But as far as like how that pattern is presented can be pretty variable. And that's where I think it gets to be pretty creative to be a physical therapist, is you get to see like, okay, how can I make this not horrible and boring for this person? Like, what are you interested in? You want to get back to golf? Okay, let's see how we can make this applicable so you can see how the boring things you're doing now will get you back to.
Sure. Right.
That
Give
thing.
them some motivation. Yeah, that makes sense. So as in your day-to-day work right now, do you work directly with doctors as far as like being understanding, what the patient's physical condition is, what their limitations might be, and is that normal? Like if you worked in a different clinic, do you just have to trust your patients, be like, oh, this is what happened to me, or do you get like a physician's note as far as like this is what happened?
Good question. I feel like my job in a hospital is a little different, is because I get the notes. I can see all of the notes from all of the doctors and nurses who have worked with a patient up until like I work with them. But in the hospital, because they're not exactly medically stable, which is why they're there, we do work within some parameters set by the doctor. So often like we don't get to work with somebody until a doctor says, hey, you need physical therapy now. You're medically stable enough to start moving out of bed and trying to progress towards your prior level. And then sometimes they'll have like blood pressure parameters, or, if they can or cannot weight bear on certain limbs, just given if there are injuries. But largely at the typical outpatient clinic, I would say it's relatively offhands from doctors, unless it was a surgery. If it's just like an old chronic injury, you get a referral, or you can just walk in if your insurance will pay. And they'll just kind of take your word and just go with it. We're trained on like the big red flags on when we need to stop and when we need to talk to your doctor. But if it's a surgery, then the surgeon will give you like a pretty detailed plan on how fast to progress them, because that's ultimately a reflection on them and their work.
Sure.
So again, it kind of
some of both,
depends.
depending on situation. It depends.
Yeah.
I guess that's what you said,
Here we
right?
are.
That's the
Yep.
That honestly, while you were talking there, it reminded me, ironic that I mean, I contacted you about this podcast a couple of weeks ago. I've been thinking, I wrote up the questions. I'd forgotten I actually had physical therapy like 10 years ago. I had a running injury.
Experience? Okay.
Yeah. So I went to a sports medicine doctor, and he diagnosed me with I had some type of tendonitis in my foot, I think. Is that a thing?
Yeah, it is.
It's been a while. Okay. And I've got very flat feet, and I had no support in my shoes, and I'd been playing a lot of basketball and doing a lot of running. And so anyway, he referred me to a physical therapist, and I went in, and I worked with I think 2 physical therapists, and they give me some good insights, some good exercises, some good I feel like there was some type of machine involved that confused me. I mean, it seemed like there
was
was
like a licensed repute. This wasn't like a back alley therapist, right?
I'm wondering.
Yeah, at the end they tried to sell me a timeshare. I mean, just kidding. That didn't happen. But no, it seemed like they had a pretty good handoff. I'm guessing the doctor explained to them at least some basics about what had happened to me. So that's why I was, I guess, mostly interested in what the situation is, both from with you, because it makes sense, obviously, in the hospital. If you're in there, you're going to be working with the doctors. But in an outpatient clinic, what you get to hear, what you get to see versus what, because I know I told the physical therapist I work with that I run, because she was asking me getting a little more information about it, and I told her, and she's like, okay, I need to see you run. So she actually took me outside and like had me run, and she's like, okay, you got to work on this and this and this. So it was good.
I have a a sticker on my water bottle that says I'm silently analyzing your gait. And it's because like how you walk and how you run really affects like why you're having pain. So yeah.
So interesting.
That's what
That
we
makes
want our
sense.
listeners to come away with, knowledge that wherever they are, a therapist may be judging them.
It's possible. You just never know.
Yes, exactly. So,
But you can now assume.
Yes, yes.
That's really funny. Okay. All right, let's move on to the next question. So my next question was, physical therapy. Is it a life habit? Like, do you have customers in a hospital? Doesn't make sense, I guess.
Well, that's okay. And I feel like we can talk largely the outpatient. That's what people are familiar with.
Okay.
And their
right.
customers, their patients, their consumers.
Right. Yeah. Are most people in it just, I'm guessing most people are in it to just get in and out. It's like a medication, but what are the scenarios where you need to do it for a specific time frame and or just indeterminate period?
I would say largely it's just kind of a fix, like you do it for a certain amount of time and ideally you get to a place where you either can manage it on your own, that if it does keep popping up, then you've got the tools that you can kind of deal with it and keep going without any like big bumps in the road. Or it's just like not a problem again for you. But there are a lot of people that will have to like periodically come back for something related to that same thing. It might not be like the exact same thing every time, but just how it manifests itself is a little differently. So I would say largely the goal is to get you to be independent with managing yourself and being able to do what you love and like try to incorporate some of those tools into what you do, so that you don't have to keep coming back. But I feel like bodies are messy, so the job security is pretty good.
Right. So generally it can be viewed as rehabilitative, right? The idea that you're hopefully going to be able to get to the point where, you can either manage it yourself or you've solved the issue, but that, there can be relapses and that you might end up coming back.
Totally.
Return customer.
There you go.
Okay. What about, so I guess, and the sticker on your water bottle gives me an idea that potentially running and or the way that you walk is a common issue that you deal with. What are the frequent physical therapy issues? Like what, I guess, and once again, I guess it depends. But
yeah, largely I would say
what are
like
all the reasons that you could have therapy?
Well, how many parts are there in a body? Just kidding. I would say.
Well, I mean, that's really it, isn't it? Right? Like,
I mean, kind of, yeah. But largely, I would say a lot of people have back pain. A lot of people have shoulder pain, and a lot of people have knee pain. Those are kind of the big ones.
You say a lot of it's focused around joints.
Yeah, at least in the outpatient. Yeah. In the hospital, it's because people get old.
Right.
But as far as like the outpatient, what people are familiar with, I think back pain is probably one of the biggest things.
And which of those, and this might be more subjective, I guess, in your experience, have better outcomes? Like as far as like being able to get people back to, 100% or at least close to it. Like if you rehabilitate a knee, are you expecting like, okay, that's going to work? Like back issues to me seem like you're just trying to manage the pain. I mean, maybe that's just my perception though, right?
Right.
Or what's your experience?
Well, I can only speak because I've only had like a few shorter weeks in the outpatient clinics for my schooling. But I think most things do get better with PT, but I find that the ones that do get better just in general are the ones where people aren't like catastrophizing their pain. And this is maybe not what you expected, but if you can not necessarily like embrace that you're having pain, but just kind of accept like, yes, I'm in pain and it's not the end of the world. And just like our trauma response and anxiety kind of feeds into how we handle pain. And then also if you're willing to like actually work to get it better.
Okay.
So I would say if
So
those are
it's more about. Sorry, so it's
no,
essentially more
yeah,
about the mindset.
Yeah, it is. Which
Interesting.
And that's
That's got to.
just my experience. I haven't
Sure.
seen everything, but
I'm sure, right? That's got to be true for you too, though, right? Even in the hospital, dealing with post-surgery things. If people have a mindset of like, I can do this, I've got a physical therapist here to help me, but I'm going to put my effort in. You're able to achieve more with them than people that are just, knocked out, not able to, are just completely down and out, right?
Yeah, totally.
Okay, that's it's probably a good life lesson. So
It is. Yeah. We could
that's
go
what we
on
do to learn it from a layman.
Yeah. We could go on a little like social commentary about how our society doesn't prepare us to like handle pain or deal with pain well.
Hey, we have
we'll
worldwide
do that
listeners,
when we
Natalie.
cover the basics of pain, which is something that we're probably overdue for.
Yeah, well, I was going to say our listeners need it at this point. I mean, we've been inflicting pain on them for years. No, like I said, worldwide listeners, I would be interested to, your experience, Natalie, is in the United States, but
Definitely.
I wonder, if that commentary about like, the mindset of patients in physical therapy, if it holds true in, say, Tasmania, openly shilling still for our Tasmanian listeners. So also quick aside from our main, so Natalie's husband, Jerem, was on a month ago. He talked about digital illustration or illustration in general. So we're really tapping into the Vogel knowledge, set. So we appreciate all that you and your whole family and extended family, which by the way, we have your brother-in-law coming on soon, and then your sister-in-law. And
cool.
So,
wow, yeah, you got a whole network here.
Oh yeah, it's a good time.
Just the Vogel family.
Okay, let's get back to PT though. Exercises and stretches that healthy people can do to promote good body health. What are some? Are there like ones, if you're walking down, you see someone with a bad gait, that sticker on your water bottle, do you ever walk up to someone and be like, you should try this?
Definitely not. Nope. No.
Okay. What are some good good stretches or exercises, or is that, once again, it depends?
Well, largely, I mean, it does depend. I would say like the very best exercise ever is one that you are going to do consistently. So whether that's like swimming or biking or running or walking or hiking, like whatever, that's the best one. And it's better than none. And 5 minutes is better than 0 minutes. So that's like what I would always pitch first. But as far as like common gait abnormalities, if we wanted to get into that,
sure.
There's a muscle called your gluteus medius that sits like on the side of your hips. That essentially, so if this glasses case that's level, I'm holding it between my two hands, is your pelvis. My hands on either sides is like your gluteus medius. And when you walk, one of these muscles is basically off. It's not working. So it has to be supported and kept level by one side. And when it doesn't, it kind of tips your pelvis down on the opposite side. And that can cause a lot of like weird hip rotations and just a lot of like hip pain. And I would say largely just because we move in straight pathways. We don't do a lot of side to side movements. That's the muscle that is like weakest in us. And so you can work that by doing like side lunges or side steps, or like single leg bridges, those sorts of things.
Interesting. So that would be you'd recommend that for everyone, not specifically runners or athletic people, but if you just want,
I would say largely probably 95% of us has pretty weak glute medius.
All right.
But I also don't work in the outpatient setting, so that's just, from what I see and my little experience.
Do you have like a little notebook that you like take notes on? Be like this person. I mean, if you're judging people's gait, you're like,
No, it's
they
a fun
have.
just pastime. It's nice that I can just like be like, oh, that's interesting, and then just kind of let it go.
That's fun. I've commented before. I used to swim. I was a big swimmer in high school, as was Matt. Actually, we and when you see someone swim, as a former swimmer, and I also was a lifeguard, I was in the water for a long time.
Uh-huh.
And so as soon as I see someone swim, I'm immediately judging them. Like immediately. I look at someone swim and I'm like, no, that's wrong. No, that doesn't. And just like some snap judgments also about the ability, how far they can swim, how fast they can swim. Like immediate.
There you go. Yeah, it's
And
it's probably pretty similar.
right, exactly. And I don't do that with people walking, and I don't do it with people running. But it sounds like that's what the physical therapists, yourself included, are able to do, or be able to look at someone and be like, okay, they have this problem. So it's like a superpower,
well,
Natalie.
Although I will say that in general, unless you're having pain with walking or running, if you do have an abnormal gait, it's not necessarily bad. So
is this one of those "you're special just the way you are" kind of messages, or?
Yes. Wow, that's beautiful. Yes.
Right. Okay. Now, like I said, you've been in the field a couple of years. You've been working in a hospital, and so you've probably seen lots of, well, I guess probably both successes and maybe even failures. But what are the big successes you've seen in your time as a physical therapist?
It's hard to find like one patient. I've been kind of thinking on this since you gave me the questions ahead of time, and I really couldn't think of like one particular patient where it's been like awesome, because a lot of the things that I see in the hospital don't necessarily have like beautifully tied up endings, because like I see someone who's been in a car accident and has a brain injury now, but I'm able to like get them to sit up for the first time and to even sit up in a way that they can support themselves and I'm not having to hold them up, or I get to like take them on a walk for the very first time since, they've had their spinal cord injury or a stroke. And that's pretty cool.
Yeah, that's really cool. That sounds super scary though, too. So you've done that before? That sounds so scary to me.
Sometimes it gets pretty dicey.
Are people like what do you work with a team, by the way, Natalie, or is it just you? You're the physical therapist?
Oh, no, heavens, no. I don't even know. There's at least, I would say maybe about 20 physical therapists at the hospital I work at, but we also work very closely with the occupational therapists, and their team is about as big, and then the speech therapists, where there's like 8 of them. So we kind of all coordinate and talk about how patients are doing and who's on our caseload and that sort of thing. But I do, yeah. So I guess to answer your question, yes, I do work with the team.
Okay. So walking the halls with the spinal cord injury, that sounds pretty crazy. Is that, like you said, you've seen some pretty traumatic injuries. Those are those the big ones? Like you said, neurological issues as well. Do you do physical therapy, like helping people swallow? That's
the speech therapists.
Okay.
I don't really know the anatomy of the mouth and the throat very well, but sometimes we can co-treat in that, like, I can get someone sitting up because you should not really be eating laying down. So I can help sit them up, and then the speech therapist can come and see how they're swallowing or give them tools on how to do that, or tools on how to communicate better, because sometimes that's impacted with brain injuries or strokes. So it's kind of cool.
When you're doing your physical therapy in the hospital, do you get a team of nurses to help you? Because I'm guessing, if you're walking the halls with a large male that's had a spinal injury, if they start collapsing, well, what are your options?
The only real option we have, everybody uses we put a belt around their waist called a gait belt, and we hang on to that in case they're wobbly. Ideally, I will be able to assess their gait and their strength to gauge correctly how far they can go and get back, or I'll bring a chair or have somebody like follow me with a chair. But if they're going down, which knock on wood, that hasn't happened to me yet, you help lower them to the floor just so that they don't get hurt. But I'm not trying to like lift them up at all. We're just trying to get them
Okay.
down safely, and then we can find a way to get them back into a chair to get them back
Okay.
to their room.
So these are the things you've trained on. Then it sounds like you know, like you assess beforehand. It's not like you just casually go for a stroll in the hall. Be like, let's see if you can do a half a mile today.
Yeah,
Like,
no, definitely not. It's very like I assess. Kind of my process is like I assess how they're moving in bed, laying down, and then I get them sitting up at the side of the bed and make sure their vitals are stable because sometimes the blood pressure tanks. And then I see how their strength is. If they can't kick their legs straight at the side of the bed, then we're definitely not going very far. And then I see how they're doing standing up, how their balance is. We take some steps at the side of the bed, see how that goes. And then if I'm like checking all these boxes, then we can try to go out and back. And I'm not saying I'm perfect. I've definitely taken patients farther than they could go. And we've had to take an emergency seat in the hallway on a office chair. Yeah. And I unfortunately did have a patient who died on me one time. That's not
oh my gosh.
the usual, but yeah, that has happened. That wasn't
That's
anything
traumatic.
I did, but it feels like
right.
it. But
Yeah. That's, well, I guess that would somewhat be expected if you're working with people that have these super traumatic injuries.
Yeah, it was, and it was in the cardiovascular ICU, so we just didn't, yeah. It was,
that's tough though.
It's not expected, but yeah, I mean, anything's game in the hospital, basically.
Right.
Anything that you can think of could happen, will happen.
Happens. Yeah, that's, I've told you, Natalie, but Johnny, the podcast host that comes on very frequently with us as well as a doctor. Yeah, the stories of the hospital. I mean, that could be its own probably is its own podcast somewhere.
Probably is. But yeah.
Okay. You already talked a little bit about the schooling. I guess your schooling specifically, and then you mentioned some of the other specialties. You do ongoing courses then to maintain your degree, or what does schooling look like, both what you've already done and then what you do to maintain your license?
Sure. So to get a degree in physical therapy, it's actually a doctorate. So you have to have a bachelor's, and then you'll have to meet certain like prerequisite requirements, and those vary depending on the school. And then I think most schools are 2.5 to 3 years. My school had like short summer breaks, and so mine was full 3 years. Some people do like 3 years straight through, others do it in 2.5, but regardless, you hit the same kind of general education, focuses on like a neuro course, an orthopedics course. Now I'm like blanking on everything I ever learned. And you'll do like a little bit of research, those sorts of things. And then after, you have to pass the boards, essentially, where the NPTE is the big test, where it's a national test, and it's 4 hours long, and you have to wait for your results. But then you'll have to also pass a state test for what the laws are around, like what you are allowed to do in the state.
So does that mean that every state, if you were to move, Natalie, you'd have to get relicensed? Is that an easy process, or?
Largely, it is. I think it's pretty easy. I think you have to pay a fee, and then a lot of the legal exams are open book. From what I understand, I haven't had to do that. And then there are some states in the West, I think like Washington, Oregon, maybe Idaho. I don't know who else, maybe Arizona. There's like a pact, basically. So if I'm licensed here, I don't have to do a lot to get licensed in Oregon or in Idaho. But it's not a national certification. And then to maintain my license, I have to get like 32 hours of continuing education every 2 years, I think. I might be spouting all of this exactly wrong, but this is kind of the
learn it from a layman here. They get what they pay for.
Okay, perfect.
Yeah.
I plan to do it every 2 years, so that way.
Yeah. Well, I mean, you obviously there's continuing education courses that you do take, regardless of whether or not specifically 32 hours. Are those done in like with conjunction with your employer? So like, can you working at the hospital? Are there like, can you sign up for courses there, or are these like national courses that you sign up for? That makes sense. I don't know.
There are always tons of national courses that you can take. The hospital I work at, we do have occasional courses where they do offer like an hour here and there. And then sometimes they'll like reimburse me to go to a course as it relates to like my role in the hospital.
Okay.
Because I'm not an outpatient therapist, they're probably not going to pay me to go and learn like how to cure back pain, because that's not something that I like really deal with. But yeah, if you're lucky, then your employer will pay for some of that. There's as many courses for whatever you might be interested in. It's just a matter of doing the research and finding what is applicable to where you are and what you want to learn about.
Okay. What this probably is outside of your ken, I guess, but internationally, if you were to move to Canada, is the license like completely different? You'd have to like, I mean, but your degree transfers, right? So then it would just be.
Yeah. So I may or may not have done a little bit of research on this actually.
Oh, yeah?
And I think the US, it's a doctorate, but I think in a lot of other countries, it's actually a bachelor's degree. And I guess I don't know how far the scope goes, if they do a lot of like inpatient physical therapy, like what I do, or if it's mostly outpatient. But I would be able to, I'd have to take their national license exam,
right.
Which I would probably need to study for, since I've been kind of in my one tunnel, my one lane for so long.
Right.
But
okay.
Yeah, I'd have to pass whatever national boards to the other countries.
All right, that's good to know. All right, what about, so obviously we had the COVID pandemic a few years ago, and everything went remote. Physical therapy seems like something that you want to do in person. Are there, and I don't want to know how it lined up with your, your schooling and your clinic and all that you had to do. Were there remote sessions? Can you do remote physical therapy?
You can. I think it's a lot harder to do, because in trying to like suss out where exactly the problems are with how somebody's moving and why someone does certain things, like there are certain tests that we can do to like rule out certain things or rule in like muscles or nerves or joints or whatever. So those are so hard to explain to somebody else on how to do to themselves, if you can even do it to yourself. But if you have kind of established what the problem is with somebody and you're just trying to like progress things, as someone gets out of like the more painful parts of their situation, I guess it's more trying to transition them to like exercises and increasing their tolerance and things. So I think it'd be a lot easier to do a remote session once you've established that. But as far as like a first time trying to figure things out, I don't really know how well that works with somebody. But I know it had to happen for a lot of people during the pandemic. So
you didn't personally have to do it though.
I was in my clinical rotation when it was really bad, and I did have an instructor who had one patient that she was seeing remotely, but she'd had a relationship with that person for several months, and so she knows exactly like where to take the session. So, but yeah.
Okay. All right, so we're on our last question, but I'm going to throw you a curveball here on the last question. You already before the podcast told me that recent developments are not like something that you've seen necessarily, at least in the work that you've done. But what about prosthetics?
Oh man, so there's actually a master's degree that is prosthetists and orthotists.
Okay.
That is super fascinating, and I don't know enough about, but there's I feel like there's always cool things happening with the different like joints that they have available, especially with like any upper extremity prosthetics, the way that they have to creatively problem solve like grip and things.
Hmm.
Um, but yeah, that's a
You
really
haven't.
neat field. I don't know
Okay.
a lot about it.
You haven't worked with anyone that's like I said, you're in the hospital. No one's like recently had like a new prosthetic limb attached, and you've been assigned to that case.
No, so I would see someone right after they have the amputation.
Oh,
And
okay.
at that
Right.
point, it's a really fresh wound. Things are super swollen. So you don't want to get fitted until things are super healed and desensitized, because after they have typically amputated a limb, your brain is trying to rewire where that part of your, typically it's the leg. So that's why I'm kind of thinking about it in the leg. So like they're
Right.
trying to remap, like, where is that foot? How am I going to cope with that? So you have to like desensitize your leg before you can like bear weight on that.
Mm.
So those are the things that I typically educate someone on, is like making sure they still have good strength, they still have their full range of motion, you're trying to desensitize the leg, and then they just kind of have to wait several weeks up to months before things kind of settle, and then they can get fitted. And they would go to a prosthetist or a prosthetist, I guess, to get that fitted. So I only see them if they've had them for a really long time, and oftentimes they're either getting a new amputation or it's like old hat and totally unrelated to why they're in the hospital.
Okay. I
Sorry
guess then
it's
no,
disappointing answer, I think.
it's a good answer. It's good because I was yeah, I mean, you obviously know the specifics of how you get the prosthetic, and that's something I'm not familiar with. Okay, last question from me then is what about so people coming up in the field? Said you're relatively new in the field, but you've been in a couple of years. Any words of encouragement or advice that you could give to people that are studying or interested in physical therapy? Any directions that they should be taking their studies, or specific useful things that, like you said, ASL for you was able to, give you a little bit of, potentially help dealing with your patients. Anything that you wish that you knew, 5 years ago that you could use now?
Oh, wow.
Yeah. So another quick
No, it's
surprise
great.
question for
It's a
you.
really good question. Um,
I guess while you're
I
thinking
guess,
about it, sorry, I
oh
was
yeah.
just going to say, like, I'd imagine languages are like ASL or potentially Spanish in the United States, something being able to communication is, I imagine, an important part of any type of relationship. So, a physical therapist and their patient being able to communicate, I'd imagine, is an important one. But sorry, that's
Yeah. No, and it's interesting you bring that up, but like in the area that I live in, the Vancouver, Washington area, we have a lot of people who speak Russian. And that's probably what I use our interpreter services for the most, even more than Spanish, and definitely more than ASL. So it's like, oh, I wish I had even thought about taking Russian,
languages,
but
right?
it hadn't occurred to me. But yeah, that would be useful right now. I guess more generally, I think everybody would make a great physical therapist, and that they would find something they're interested in. But I guess if that's something you're interested in, go for it, because even if you're not jazzed about like the typical outpatient orthopedic setting, like there's just so many different ways that you can like work in this field and like be helpful and make changes in people's lives, that even if you don't feel like you fit the general mold, like there's a place for you.
Right.
You just have to find where you want to be.
Yeah, and in the world of AI and people questioning their job security, I'd imagine physical therapists, you have to feel pretty secure. I mean,
I
people aren't going anywhere, and they're not getting healthier. So,
Yeah, no, bodies heal really well, but they also break down. So,
right.
yep.
Nice. Okay, Matt, did you have any final questions for Natalie?
No, I think you answered every question that needs to be answered regarding physical therapy. So good work.
I think Matt constantly takes digs at the end of every podcast where I've sent questions.
We're very thorough.
That's yes. Natalie did a great job, and I hope my questions were useful. But Yeah, Natalie, thank you for coming on, and thank you for the insights that you have. And we'll check back in the future and see if you and Jerem can come on and give us a idea of freelance versus not freelance work, because it sounds like we have a little bit of a disagreement on what that's.
Yeah. I think we're both pretty happy with where we're at individually in that sense. So yeah.
Right.
But thanks
Cool.
for
Well,
having me.
thank you, Natalie, and we'll be back in the next podcast. Thanks.